Millions of seniors take at least one medication that quietly strips muscle strength. You don't feel it right away. You just feel weaker, slower, less steady. Today, we uncover the categories most responsible. Dr. Shigeaki Hinohara used to speak about longevity in a way that still haunts me because it's so simple and so ignored. Longevity isn't protected only by adding new treatments, new supplements, new routines, and new biohacks. It's protected by understanding what quietly drains vitality when no one is paying attention. We assume the enemy is always something obvious: sugar, fat, genetics, aging itself. But the truth is, the body is often worn down by small, consistent forces that never feel dramatic enough to demand our attention. That's why you can wake up one morning and realize you're not the same person you were a year ago, and you can't pinpoint exactly when it started. Here's the shock that many seniors tell me with confusion in their voice. "Doctor, I'm eating well, I'm walking, I'm doing what they told me." They say it like a confession, like they're pleading for proof they didn't fail. And I believe them, because they're often doing exactly what mainstream advice recommends. Some protein, some walking, maybe a light stretch routine, yet they're losing muscle rapidly. Their thighs shrink, their posture collapses. They start using their hands to push up from a chair. They stop carrying heavier grocery bags. They avoid stairs. And nobody connects the dots because the mind is conditioned to treat muscle loss as a normal tax of aging rather than a biological warning sign that something is pushing the body into breakdown. Hinohara had an analogy that fits perfectly here. The body is a finely tuned instrument. When it's tuned well, you don't just live longer. You move better, recover faster, and stay independent. Medicine can absolutely heal. And I'm not anti-medicine. I've prescribed these drugs. I've seen them save lives. But even a good instrument can be mistuned. And when that happens, the sound dulls, the response slows, and the precision fades. A medication can help one system while quietly destabilizing another. And the cruel part is that the loss is subtle at first. You don't feel your muscles disappearing the way you feel a fever. You feel it as fatigue, as heaviness, as "I'm just slowing down." And because it's gradual, it becomes believable. This is where Dr. Peter Attia's framing lands like a hammer. Muscle is a survival organ, not a vanity organ, not a gym organ, not something you only worry about if you want to look younger. Muscle is what keeps you out of nursing homes. It's what keeps you able to catch yourself when you trip. It's what protects your bones, stabilizes your joints, supports your metabolism, and gives you reserve when you get sick. When muscle is lost, the risk of frailty, falls, and dependence rises sharply, and the body enters a state I call catastrophic decline, where it begins to cannibalize strength it took decades to build. That is why anything that erodes muscle is not a minor side effect. It's a direct threat to independence. And yet here's the blind spot that still shocks me. Prescriptions are rarely reviewed through a muscle loss lens. Think about how often medications are assessed by blood pressure numbers, cholesterol numbers, glucose numbers, and symptom control. Those are important. But the body doesn't live on lab values alone. It lives on function. It lives on the ability to stand, walk, carry, climb, and recover. In real life, a successful prescription that makes you weaker is not always successful. Many people accumulate medications over years, one added here, another added there, without anyone stepping back to ask the question that matters most after 60. What is this doing to your strength? I need you to hear this clearly, because fear can push people into dangerous decisions. This is not about stopping meds blindly. That's not what responsible medicine looks like. This is about awareness and protection. It's about understanding that certain drug categories can accelerate muscle loss, especially in older bodies, and that you have the right and the responsibility to ask your clinician to review your list with your strength in mind. This is about protecting the part of you that keeps you free. Independence isn't just a concept. It's your ability to bathe yourself, cook for yourself, walk without fear, get up from the floor if you ever fall, and live without needing someone to rescue you from your own body. So here is what we are going to do together. You will learn 10 common medication categories that raise muscle loss risk, why they do it biologically, who is most vulnerable, and how to counteract unavoidable use with precise, practical steps. I will explain the mechanisms in plain language, how certain drugs blunt the hormones that build muscle, disrupt mitochondria that fuel movement, deplete electrolytes that make muscles contract, sedate the nervous system so you move less without realizing it, or sabotage nutrient absorption so your muscles starve even when you eat enough. This is not a lecture. This is a protection plan. Before we go any further, I want you to do something simple that helps me tailor these messages and helps others feel less alone. Tell me in the comments where you're watching from, and if you're comfortable, share one medication category you've been on long-term: heart meds, diabetes meds, steroids, sleep aids, stomach acid meds, whatever it is. I read these comments and I can tell you this. When people see they're not the only one, they stop blaming themselves and start taking action with clarity. If you're ready, we'll move into the first group, the fastest muscle impact medications, because these are the ones that can shut down muscle building even when you're trying your best. The most dangerous muscle loss doesn't always come from neglect. It often comes from relief. Relief from pain, relief from inflammation, relief from cancer-related hormone activity. And that's where the trap forms, because the body interprets short-term relief very differently than the prescription label does. What feels like stability on the surface can quietly dismantle the biological machinery that allows muscle to rebuild itself. Many people assume that if a medication is common, time-tested, or even life-saving, it must be neutral to strength. But muscle is not passive tissue. It is metabolically expensive, hormonally sensitive, and constantly negotiating whether to grow, maintain, or be broken down for fuel. Muscle depends on anabolic signaling, the internal messages that tell the body, build, repair, preserve. It also depends on controlled inflammation, not the kind that damages joints, but the kind that acts like a biological spark for adaptation. When this balance is disrupted, protein synthesis slows, breakdown accelerates, and the body quietly shifts into a conservation mode. In that state, muscle is no longer protected. It becomes expendable. Certain medications interfere directly with these signals, especially in older adults whose hormonal reserves are already thinner than they were decades ago. This isn't theoretical physiology. This is what shows up in weakened legs, shrinking arms, and declining strength that seems to appear out of nowhere. Think of muscle like a construction site. When everything is working properly, there is a foreman coordinating activity, materials arriving on schedule, and workers repairing damage from daily wear. The medications in this category remove the foreman and cancel deliveries at the same time. The site doesn't collapse overnight. It just stops progressing. Then it begins to deteriorate. You don't feel pain. You feel less capable. And because the decline is gradual, it becomes easy to rationalize. The body adapts downward without ever asking your permission. This is why someone like Linda, 72, can start a new prescription and only months later realize that standing from a chair now requires momentum, or that carrying laundry feels heavier than it used to. Nothing dramatic happened. No injury, no illness. Just a quiet shift in how her body responds to everyday demands. That is often how hormonally disruptive medications announce themselves in real life. Corticosteroids, such as prednisone, are a prime example. They are powerful anti-inflammatory agents, often essential for autoimmune conditions, asthma, and severe inflammatory states. But biologically, they send a clear message to muscle tissue: break down protein, suppress repair, conserve energy. They elevate cortisol-like signaling, which is catabolic by nature, meaning it tells the body to dismantle muscle for immediate needs. In younger bodies, this damage may be partially offset. In older bodies, the loss accumulates. Muscle fibers shrink, strength declines, and recovery from even light exertion becomes slower. Aromatase inhibitors, commonly used in breast cancer therapy, introduce a different but equally potent mechanism. By suppressing estrogen production, they remove a hormone that plays a critical role in muscle maintenance, tendon health, and recovery. Estrogen is not just a reproductive hormone. It supports muscle repair and neuromuscular coordination. When it is reduced abruptly, muscle tissue becomes more vulnerable to breakdown, especially in postmenopausal women who are already operating at lower baseline levels. The loss is not always obvious at first. It often shows up as stiffness, weakness, and reduced tolerance for physical effort. GnRH suppressors used in prostate cancer therapy operate through a similar pathway in men by dramatically lowering testosterone. Testosterone is one of the most powerful anabolic signals the human body has. When it is suppressed, muscle protein synthesis declines sharply. the body shifts toward fat accumulation and muscle loss, even if calorie intake and activity remain unchanged. This is not a moral failure or a lack of discipline. It is a predictable biological response to hormonal suppression. Without intervention, muscle loss in this context can be rapid and profound. When the use of these medications is unavoidable, the body needs counter-signals. Resistance training 2 to 3 times per week sends a clear message that muscle is still required. It does not need to be extreme, but it must involve real effort against resistance. Protein intake in the range of 2 to 1.5 grams per kilogram of body weight provides the raw material muscle needs to rebuild. Regular strength checks, such as chair stands and grip strength, act as early warning systems. They reveal decline before it becomes disabling. These measures do not negate the medication's purpose. They protect the rest of the body from becoming collateral damage. This first group matters because it works fast. Hormonal and inflammatory disruption accelerates muscle loss more quickly than many people realize, especially after 60. And once muscle is lost, it is far harder to regain than to protect. The next category is more subtle, more widespread, and often dismissed as harmless because it targets the heart. But what improves circulation does not always preserve strength. Medications designed to protect the heart often carry an assumption of total safety, as if improving circulation automatically preserves strength. But the body doesn't work in straight lines. After 60, muscle function depends not only on blood flow, but on energy production inside the muscle cell, precise electrolyte balance, and the nervous system's ability to activate movement. When any of these systems is quietly disrupted, muscles may receive blood, yet lose the capacity to turn that supply into force. The result is not sudden weakness, but a gradual thinning of strength that feels like aging and is rarely questioned. Many cardiovascular medications influence mitochondria, the tiny structures that generate energy inside muscle fibers. When mitochondrial efficiency drops, muscles fatigue faster and recover more slowly, even during ordinary activities. This doesn't always show up as pain. It shows up as legs that tire sooner, stairs that feel heavier, or a growing hesitation to push the body the way it once could. Over time, reduced effort becomes the norm, and muscle tissue adapts downward to match the lower demand. Electrolyte balance plays an equally quiet role. Some heart and blood pressure drugs alter levels of potassium and magnesium, minerals that control muscle contraction and relaxation. When those levels drift, muscles may cramp, feel unresponsive, or lose coordination. These changes are often subtle enough to be dismissed, yet they influence how confidently a person moves. Less confidence leads to less movement, and less movement accelerates muscle loss, especially in older adults whose reserves are already limited. There are also medications that dampen the body's natural stress response. By lowering heart rate and blunting adrenaline signals, they can reduce exercise tolerance. Physical effort feels harder even when the task is simple. The body adapts by conserving energy, and muscles that are no longer regularly challenged begin to shrink. None of this happens overnight. It unfolds quietly, reinforced by the belief that weakness is simply part of getting older. What makes this category so important is its reach. These medications are common, often necessary, and usually prescribed long-term. The muscle effects are rarely discussed, not because they are rare, but because they are gradual. And gradual loss is the easiest kind to overlook until independence begins to slip. Protect your strength and independence. Subscribe now for clear, honest guidance your muscles depend on. Some medications don't weaken muscle by attacking the tissue itself. They work more quietly, by lowering the volume of the nervous system that keeps the body alert, responsive, and in motion. After 60, this effect matters more than most people realize, because muscle survives on use. When nerve signaling softens and alertness fades, movement naturally decreases, and muscle loss follows as a predictable biological consequence. The nervous system is the switchboard between intention and action. Every step, every reach, every correction of balance begins as an electrical signal. Certain medications dampen that signaling, creating a state that feels like calm, relaxation, or emotional smoothing. On the surface, this can seem beneficial. Beneath it, the body moves less often, less confidently, and with less precision. The reduction is rarely dramatic. It shows up as longer periods of sitting, slower transitions from standing to walking, and fewer spontaneous movements throughout the day. Muscles interpret this silence as disuse. This is why sedation is not biologically neutral. When alertness drops, so does coordination. When coordination drops, the brain becomes more cautious about movement. Over time, the body adopts a lower baseline of activity without conscious decision. Muscle tissue, which is energetically expensive to maintain, responds by shrinking. After 60, this process accelerates because the threshold for muscle preservation is already higher than it was earlier in life. Medications such as benzodiazepines illustrate this clearly. By enhancing inhibitory signals in the brain, they reduce anxiety and promote sleep, but they also slow reaction time and impair balance. The risk is not only falls, but the gradual reduction in movement that precedes them. Certain antidepressants can produce a similar effect through fatigue and neuromuscular slowing, subtly reducing daily physical engagement, even when mood improves. Someone like Eleanor, 78, may not describe herself as weaker. She may simply say she moves less. That distinction matters. Muscle loss driven by nervous system dampening is indirect, quiet, and often misattributed to age. Yet the mechanism is consistent. When the lights dim, the muscles stop responding. And when that pattern persists, strength fades without ever announcing its departure. Some medications weaken muscle without ever touching the muscle itself. They interfere with digestion and metabolism, quietly reducing the body's ability to absorb what muscle needs to survive. After 60, this matters more because digestive efficiency already declines. When absorption falters, muscle tissue can be undernourished even in people who eat well. Medications that suppress stomach acid can limit the release and uptake of protein, vitamin B12, magnesium, and other nutrients essential for muscle repair and coordination. Over time, this creates a subtle deficit that shows up as thinning limbs and slower recovery. Others alter glucose metabolism in ways that increase the risk of vitamin B12 depletion, which weakens nerve signaling to muscle. The body may appear stable on the surface, yet strength fades because the supply line has quietly narrowed. Rue medicine, as taught by Shigeaki Hinohara, protects the whole person. Muscle loss after 60 is often shaped by medical signals, not inevitability. As Peter Attia reminds us, muscle is a survival organ. When strength is preserved, independence, recovery, and dignity endure.